Thank you for joining me today. I know that you guys have a busy schedule with your classes and everything. So it's really important that you guys are here. This is the first webinar, the series of 3 for our leadership curriculum. This one is entitled Physician Leadership and the Triple Aims for Healthcare Reform. I hope that you guys were able to do all of the pre-readings and watch the video, which we're very lucky to have our guest speaker be Dr. Mark Smith, who is an NMF alum. Dr. Smith is was the founding president and chief executive officer of the California Healthcare Foundation, and he served in that role from 1996 to 2013. For those of you who are not familiar, the California Healthcare Foundation is an independent philanthropy with assets of over $700 million, and is headquartered in Oakland, California, which apparently is much warmer than the East Coast right now. And they're dedicated to improving the health of the people of California. Dr. Smith, as I mentioned, is an NMF alum, and he is a board-certified internist. He's a member of the clinical faculty at the University of California, San Francisco, and an attending physician at the Positive Health Program for AIDS Care at San Francisco General Hospital. So I hope you guys enjoy your webinar today. Dr. Smith, over to you.
Great, thanks very much, and good morning or good afternoon, depending on where you are. I was asked to talk about physicians and the triple aim, and so that's what I'm going to do in 20 or 25 minutes, and then have hopefully equally as much time for any questions, comments, responses, discussion you'd like to have, and I hope you'll speak up when we get done, and let me see what you think. So let's get started. Old friend and teacher of mine once said, when you're talking to a group of people, you should always tell them what you're going to tell them, and then you tell them, and then you tell them what you told them. So this is the part where I tell you what I'm going to tell you. I want to talk briefly about 4 things today. First is to talk a little bit about what the triple aim is and how it differs from the ways in which physicians have traditionally been taught to regard what it is they were trying to do in the practice of medicine. Second, say a little bit about health reform, both health reform with a capital R and with a small r. I'll explain what that means. Third, talk about physicians' roles, particularly in pursuing the triple aim, and some recent developments I think represent an important departure from the traditional reluctance of physicians to take on the task of cost containment, in part because they identified it with threats to their own autonomy or salary. And then last, I'd like to talk about the issue of self-care, which I think is one of the brightest horizons for ways in which we can achieve the triple aim in the future. So that's what I'm going to do. The term triple aim was introduced by Don Berwick and Tom Nolan and John Whittington in an article in Health Affairs in 2008. And when Dr. Berwick became the administrator of CMS, actually became the kind of official mantra for what CMS was trying to achieve. And though for a variety of reasons the term may not be much used in the government anymore, it remains, I think, the most advanced thinking that we have about what our healthcare system should be trying to achieve. So what are the aims of the triple aim? They are to improve population health, to improve patients' experience of care, and to reduce per capita cost in the healthcare system. Now, if you contrast that with what, at least implicitly, I was taught when I was at your stage of training about what I was trying to do, I was taught really that I was supposed to pay attention to the individual patient in front of me. That was my focus. That was my be-all and end-all, and I was trying to achieve quality more or less as I defined it. What physicians and other professionals define as quality, the appropriate choice of antibiotic, the appropriate diagnostic test, the appropriate therapeutic option. This is, I think, an important departure from that perspective. First, because it talks about population health. As a system and as individual clinicians, we should be concerned not just for the patient in front of us, but for all the diabetics in our practice, or all the hypertensives in our city, or all the people with chronic arthritis in our country. In part because our healthcare system has now become so complicated and so intertwined, we can't simply think about the effect on a given patient, but we've got to be concerned with, and we now have the tools to look into and to improve the health of populations. Second, patients' experience of care. And frankly, until relatively recently, this was kind of derided as bedside manner. And there was kind of this thought among professionals that what patients thought about their experience, that was mere amenities, and we were to be concerned about quality, which was defined often as something different. I ask you to think about your own experience as a patient or the experiences of your family members as patients, and I think you quickly come to understand that such things as, were you treated with dignity and respect? Did you understand the medications you were supposed to take and how you were supposed to take them and why you were supposed to take them? These are things that are important measures of the quality of our system, and often they are things that can only be ascertained by asking patients themselves. You cannot cannulate an orifice to determine whether a patient was treated with what he or she thinks was dignity and respect. You've got to ask them. So the patient experience of care should be an explicit aim of the system that we're trying to construct and run. And then lastly, of course, per capita cost. And that will take up a lot of what we're going to be talking about from now on. It is, I think, though, important for us to acknowledge that everyone involved in the healthcare system now has to be concerned about this issue because our system has largely priced itself out of the reach of people who need it. And so we have to be concerned about per capita costs, and there is broad acknowledgement across the political spectrum that this is an important, even a critical aim for the healthcare system today. I was privileged to chair a committee of the Institute of Medicine that put out a report called Best Care at Lower Cost, the Path to Continuously Learning Healthcare in America. And part of what we were trying to do was to update the findings of the seminal work, Crossing the Quality Chasm, which was done a decade earlier. And in brief, what we found was that the problems of excess cost and wasted resources had frankly not gotten much better, but we tried for the first time really to quantify and to point out complexity as a tremendous challenge in our system. We also tried to point out some new tools and levers that we had to deal with old problems, including the growing use of electronic medical records, which allows us really for the first time to economically survey what is happening in care, the growing use of computers in the lay world, that is to say that virtually all of our patients now carry around in their pockets a computing capacity that would have been unthinkable even a generation ago. And a number of policy levers that we have, in particular the growing capacity of organized health professionals in organized systems to learn new things that are happening and to apply new knowledge, what we call learning capacity. Let me talk just for a second about cost. And this report received a lot of publicity for the fact that we pointed out once again that something like 30% of all the money we spend in healthcare is of low or no value or even harmful to patients. But you've got to look at our spending cumulatively. This is a graph from my former foundation about how about the cumulative effects of healthcare costs rising more quickly than those of the overall economy, and what happens when you do that year after year after year after year. This is what leads to people being uninsured. Let's be clear. It's not like the country sat down and said, oh, let's make sure some people can't afford health care. The reason people can't afford health care is because it costs too much. It costs more than individuals can afford. It costs more than many companies can afford. And frankly, it's now beginning to cost more than governments can afford. So it's important to point out that the backdrop for everything we're talking about is the result of this cumulative increase in health care over the last 2 decades or so. But we also tried to point out the role of complexity. This is a graph of how many medical journal articles are published every year. And those of you who are struggling to keep up with whatever medical specialty rotation you are on surely understand that the old presumption, which was that a doctor in, say, gastroenterology would keep up with his or her specialty by reading the journal articles in that specialty, that's nonsense. You can't possibly read all the journal articles, even in your specialty, your subspecialty. let alone if you're a general internist or pediatrician or family practitioner. So it's important to recognize that as medicine and our biomedical knowledge have advanced, we now have far more tools at our disposal. This is a graph of the diagnostic complexity that comes into play. And this is only going to get worse or better, depending on your point of view. And so in talking to those of you who may still be using SOAP notes, I used SOAP notes when I was at your level of training. Remember subjective, objective assessment and plan? SOAP notes were developed and promulgated by a guy named Dr. Lawrence Weed, who has a new book out which says, I think quite succinctly, any system of care that depends on the personal knowledge and analytic capabilities of physicians cannot be trusted. Now, when you read that, if it strikes you as combative or confrontational, it's not meant that way. It is meant to acknowledge that many of our problems today are the results of our prior successes, and in particular, the complexity of modern medicine. The number of diagnostic and therapeutic options that we have available now surpasses the capacity of the human mind to manage unaided. The number of maneuvers that we can make, just doing an MRI, if you think about getting an MRI on a patient, it is a choreography of dozens of individuals in a system, each of whom has to get their job right, to get the picture taken in the right way of the right organ, interpreted correctly in order to be used for diagnosis or therapy. And so the notion that modern medicine is between you and your personal physician, a much-used kind of rhetorical flourish, is actually quite dangerous because it's absolutely incorrect. So to go back to the triple aim, this is the way I would sum up the results of that study and much other work that's been done. The past half-century has seen unprecedented knowledge generation and technical innovation in biomedical science, and there's much more to come, but our systems for choosing, training, deploying, and paying the healthcare workforce and organizing their work have not kept up with the biomedical science. So that's the backdrop for everything we're talking about now. How we achieve this triple aim and the role that physicians have to play within it has to be seen in the context of an enormously complex system that can really work miracles for patients, but which cannot be managed by the old methods because there's simply too much to manage. Now let's talk about health reform for a minute. Health reform with a capital R, what we know as Obamacare, or the ACA, Affordable Care Act. How big a deal is it? Well, this was the Vice President's term, and I won't repeat it, but it's not my term, it's his. Let's be clear, however, that part of the purpose of Obamacare was to reduce the kind of irrational variation in your access to health insurance coverage based on where you happened to live. For a variety of reasons now, those inequities or inconsistencies are actually now greater than they were before Obamacare, in part because they depend on the question of whether the state in which you live has expanded Medicaid or not and has adopted a state exchange or not. And so, for instance, my home state, California, has said yes to both of those. The great state of North Dakota has said yes to Medicaid expansion, but no to an exchange. The great state of Utah has said no to Medicaid expansion, but yes to an exchange. And the great states of Florida and Texas, where a vast percentage of our uninsured people reside in the United States, has said no to both. So as you read newspaper articles and as you think about the upcoming Supreme Court decision, which may deal a very, very crippling blow to Obamacare, a lot of what we read in the paper and we hear in the political talk shows and the talking heads on Sunday morning has to do with health care reform with a capital R, this piece of legislation. Very important legislation, deals mainly with insurance coverage, but also affects a number of aspects of the delivery system in an effort to improve quality and reduce costs as well. But I would argue that no matter what happens with the next Congress or the Supreme Court or the next presidential election, there's a set of health reform with a small r that is going on that preceded Obamacare and that will survive it, influenced by it but not predicated on it. What are those things? First, consolidation. No matter where you are in America today, you will see hospitals buying other hospitals, hospitals buying physician practices, dialysis groups buying medical groups, private equity companies buying failing hospital chains and opening them up again, on and on and on. Everyone is trying to get bigger, trying to consolidate, often in the name of clinical integration, but in reality, in my humble opinion, more about developing market power, that is to say, the ability to get so big that you can charge a higher price. What else is going on? There is a broad consensus on cost containment. No matter what the politician before you says, particularly when they're running, there is very broad agreement across the ideological spectrum that the fiscal solvency of the United States in the future depends on our getting a handle on health care costs. There are wildly divergent ways of doing so and different ideological assumptions about the best way to do so, but that it must be done is really not arguable anymore. Third, there is a broad consensus now enshrined in official government policy that we would like to move the bedrock of payment from volume, that is, how many surgeries did you see, how many endoscopies did you do, how many beds do you have filled, to value. That is to say, how are you adding to the health of the patient? This is a hugely important issue because, remember, 30% of what we do in healthcare is of low or no value, and a fair proportion of that is driven, frankly, because providers get paid to do things. I won't go into that anymore. You're probably familiar with those arguments. Some of you will be working in places that are trying to implement this. Let me just say about this, Yogi Berra once said, in theory and practice, theory and practice are the same. In practice, they're not. So it's all very well to talk about paying on value, but exactly what that means, how you measure it, and in particular, the transitional effects on institutions and individuals who've been paid on volume their entire clinical existence or career, those are the difficult problems to solve. There is disintermediation of professionals, by which I mean, if you think about the way you make travel arrangements, the way you shop, the way you do research, those of you who are medical students are probably young enough to have grown up in an era in which you presume that you will do these things for yourself. I am old enough to remember when you needed a travel agent or a librarian or a teller to do things that we now do for ourselves. The removal of those professionals, that is, taking them out of the middle between you and the thing you want to do, is called disintermediation. And this is increasingly going to happen in healthcare as well. One form of it is the democratization of health information. All of us and most of our patients now have access to reams of medical information that a generation ago would have required a trip to a medical library and a faculty ID or a subscription to some fancy computer service. So more and more of our patients have access to similar or the same information that we have access to. Let me point out, by the way, just in passing, that although each of these has its particular form in the United States, and the first one is quite particular to our country, each of these things is happening to a greater or lesser extent all over the world. And so while it is very common for people to look to a system in another country and want to convince us that that is the answer to our problems, if only we did it the way they do it in the UK or Germany or Canada, the fact is that every country struggles with the tension between the demand for health care and what they're able or willing to pay, and every country is struggling with these same transitions as well. So what does this mean for you, for your professional futures? I'll describe quickly what I think the main tenets of 21st century healthcare are. First, for many generations, healthcare was largely reactive. That is to say, we'd wait until a patient had something bad happen to them. They'd come in the office, we'd try to fix it, we'd send them back out, Or they'd come in the operating room, we'd fix it, we'd send them back out, and then wait for something bad to happen again. Increasingly, we're trying to be proactive about disease. This is very much consistent with a switch from a purely curative system to an increasingly preventive system. Both of these changes are possible now because of the increase of biomedical knowledge. The reason that we want to control your lipids is because we now know that your lipids are an important factor that predicts your cardiovascular health 20 years from now. It is possible for us to be proactive and preventive precisely because of the progress of our biomedical knowledge. That's an important thing to remember. Many of the problems that we face today and challenges are the result of previous successes. That is part of why I am and would urge you to be optimistic rather than grumbly and bitter and bitchy and moaning about all the problems. The problems we have are the results of previous successes, and I'm confident that these are problems that can be overcome with the progress of biomedical and other science. Our healthcare used to be individually based. Increasingly, it is team-based. There is no reason why doctors should do nurses' work. There is no reason why nurses should do technicians' work. There is no reason why technicians should do patients' work. And there's very good reason to think about who can do what safely, effectively, and economically. And that involves increasing the use of team-based care where people work to the skills and effectiveness that they have. Our healthcare used to be eminence-driven. You would do what the famous professor said, or what your teacher back in residency said, or what somebody published in an article based on his or her opinion. And increasingly, healthcare is evidence-driven because we have the capacity to aggregate the collective experience of 10,000 patients over 15 studies. Healthcare used to be hospital-centric and is increasingly community-centric. 2 years ago, this slide said clinic-centric, but it's now clear we are able to do things in drugstores or Walmart that we used to do in outpatient clinics or emergency rooms, and in my opinion, we should. There is no reason why we should be doing tests for strep throat in an institution whose overhead is driven by the requirement to have surgeons on call and crash carts and oxygen tanks. So increasingly, we can take care of people in their homes and in other settings that are more economical and, remember the triple aim, more convenient for patients as well. Our care used to be mainly biomedical. It is now increasingly biomedical and psychosocial. It's clear that in America, the vast majority of chronic disease is caused by things whose prevention we already understand. It is not driven by infant diarrhea. It is not driven by Ebola and cholera. It is driven by smoking, diet, exercise. So increasingly, the task for us is not just to understand people's pathophysiology, but to understand people's social circumstances and psychology so that we can apply the biomedical knowledge that we know can improve their health. Remember, the triple aim is not just about delivering services, it's about improving the health of the population. And improving the health of the population in the United States and in most developed countries increasingly requires a combination of biomedical and psychosocial expertise. And then lastly, as I said, a generation ago, physicians and others were paid mainly on how many things they did. Increasingly, we will be paid on the basis of value. And we will be paid to take care of patients who used to be largely passive, even if their passive aggressiveness worked its way out in not doing the things we suggested they do. But frankly, patients are increasingly active, are increasingly acting like consumers, in part because of insurance benefits design and in part because of the democratization of information that I talked about before. So what this means is that for many of you and for many institutions, you've kind of got one foot on the canoe and one on the dock because people are caught in this transition. If you're a hospital that's being paid for half of your rooms on a per diem basis and half of your rooms on a DRG basis, you're kind of caught. This is the situation that creates the kind of turmoil and schizophrenia that we see among so many of our colleagues today, and you will be living and maturing and being trained and being deployed in the workforce as these transitions work their way out. I want to point out that I think there's a movement for physicians to take charge of this issue of cost effectiveness, to apply their professionalism in the new world. And I refer you to the physician charter promulgated by professional organizations of internists, family physicians, and pediatricians, which tries to update the Hippocratic Oath in terms of what physicians' responsibilities are. And here is a description of their commitments. Some of them are things that you have seen before and would go without saying: professional competence, honesty with patients, patient confidentiality, maintaining appropriate relations with patients. But I point this one to you: just distribution of finite resources. Remember, that part of the triple aim is reducing the per capita cost, and increasingly, in my view, part of physicians' responsibilities are to look at their own practice and help distinguish between high-value and low-value care and try to purge our system of the latter. One approach to that is the so-called top 5 list, which was started by Howard Brody in 2010 and now has been replicated in some 12 or 13 specialties, in which the leaders of that specialty try to identify the low-value procedures that their members are providing and persuade their members to stop doing things like MRIs for uncomplicated back pain, just as an example, or antibiotics for common viral URIs. The Choosing Wisely campaign, with which you may be familiar, now has a number of medical specialty partners. You see some of them listed at the bottom right of this screen, and is a partnership with Consumers Union to try to help patients understand that just because you think you need a procedure, or someone, including even your doctor, has told you that you need a procedure, does not necessarily mean that it is so. And if your doctor tells you you should not get an antibiotic for an uncomplicated common viral URI, it's not because he or she is trying to cheat you out of care that you deserve, and it's because you don't need antibiotics for an uncomplicated viral URI. So all of these things, the top 5, the Choosing Wisely, I think are great examples of physicians beginning to own what I believe is now part of our professional responsibility as delineated in the physician charter, to try to help use our influence to provide just distribution of finite resources. I refer you to these articles. This is Chris Castle and Jim Guest, who is the former head of Consumers Union, trying to describe why this partnership between leadership in medical specialties and the leading consumer organization in the United States, the one whose aim is clearly for consumers and not to protect health insurance company profits or government budgets, to protect consumers, sometimes means doing less rather than doing more. I want to end with a discussion of self-care. As many of you know, when I was in training, the diagnosis of strep throat required someone who'd been to school for 14 years, like me and you. Now the diagnosis of strep throat can be made in 2 minutes for $2 by a high school graduate. And yet we still require that nurse practitioners, let alone pediatricians, do this diagnosis. When I started pointing this out several years ago, some of my colleagues said, well, yeah, that's true of strep throat, but that's pretty complicated, that's pretty easy. And then I became familiar with data that suggested that patients who monitored their anticoagulation status at home with technology that was developed to allow them to do that actually did so better than specialty-oriented coag clinics. Remember what I said about you doing your own library searches, your own travel arrangements, your own banking. You don't do them unaided. You do that with technology that's been developed by the travel agent industry and the banking industry to help you navigate things that used to require professionals. So it turns out this is true for anticoagulation too. So when I pointed this out to some of my colleagues, they said, well, yes, that's just a lab test, but managing chronic disease really requires physicians because we have all this training, pathophysiology. And then I read an article that was published in JAMA last year that compared two groups of patients who had high blood pressure and high risk of cardiovascular disease. And they compared a group that got usual care in the National Health Service of the UK, and let me tell you, no matter what you may hear, usual care for hypertension in the United Kingdom is pretty good, better, frankly, on average than in our country. It compared usual care with patients who managed their own hypertension, and by managed, I don't mean just took their own blood pressure, but managed their own medication based on the results. Well, guess who had better outcomes? Actually, the patients who did self-care. And then I pointed this out, and some of my colleagues said, well, that's hypertension, that's simple. And then my colleagues at the IHI pointed out that there's a self-dialysis unit in Sweden in which patients check themselves in before the nurses even get there in the morning, hook themselves up to a dialysis machine which has been specially configured for them to use. Remember, it's like Orbitz or Google. Check themselves out. They have fewer infections and better control than the patients in the professionally run dialysis unit run by the nephrologists across campus. Now, am I suggesting that all our patients can do all their own dialysis or their own hypertension management? I am not, but I'm suggesting that some of them can. And I'm suggesting that it is possible for me to conceive of patients doing things for themselves, things that we are now currently doing for which professionals have to be paid professional wages, that are frankly inconceivable now in much the same way that I suspect travel agents 20 years ago would have felt it inconceivable that I could sit in my pajamas at night and book a ticket to Boston and back. So it seems to me that if we're thinking about the long-term future of the triple aim, that is improving health, improving patient experience, and reducing per capita costs, in healthcare as in every other service industry, part of achieving all three of those things simultaneously will be expanding dramatically the range of things that people can do for themselves. And frankly, we are in a good position to advocate that, and we have been among the principal blockers of those developments. And every year in every state you will see the Medical Association and the Nurses Association and the Pharmacists Association and the dentists and the dental technicians, the optometrists, all in kind of a food fight in the legislature about who can do what. In my opinion, this is one of the principal obstacles to achieving the triple aim, and we've got to overcome our kind of guild mentality about holding on to the things that we used to do. So this is the part where I tell you what I told you. I talked a little bit about what the triple aim is and why that's different from the traditional aims of medicine, which were to pay attention only to the individual patient in front of us. Talked a little bit about the distinction between healthcare reform with a capital R and with a small r, that is, the prospects of Obamacare versus the things that are going on in the system no matter what happens to legislation or court decisions. Talked about some of the examples of the increasing leadership that physicians are playing in pointing out low-value care and trying to convince both their colleagues and their patients to eliminate low-value care in service of the triple aim, and then pointed to what I think are some intriguing examples about the reservoir of care that is available within our patients, care that is likely to be much more convenient and satisfying to them, likely to be much more economical because it doesn't pay professional wages to do non-professional work, and likely to improve health because they can get better outcomes when they can tailor that care to their own preferences and sites. So with that, I will be quiet and turn it back over to our moderator and see if you have questions or comments or other things you'd like to discuss. Thanks for your attention.
Thank you, Dr. Smith. So I am going to be unmuting. Hold on. I'm going to mute you guys again. I'm going to unmute you guys. So if you have background noise or whatever, you can turn that down. Okay, that may not work. If you guys have, you guys have questions, you can put them into the chat box, and then I can unmute you individually. Does anyone have any questions?
Well, if not, thanks.
Okay, so Byron, are you on?
Yes, I'm on. Sorry, I can't type fast as I'm thinking. Dr. Smith, awesome presentation. Really appreciate your time, and this is actually very helpful in putting everything into a global perspective. I like everything that you were saying. One of the things I have a question that I'm questioning it is that, you know, considering the idea that patients can take care of themselves, self-care like the dialysis, hypertension, things that you mentioned, strep throat, things of that sort. I'm also considering, you know, we're graduating as medical students with $250,000 plus in loans. So we take away these revenues for money to help even pay off our loans and just the overall perspective in that sense. How does that all relate? Because I feel like if you take away some of the wages and some of the things that we're doing, although in some sense it makes sense because patients seem to get better outcomes in some categories, as you mentioned, like dialysis and hypertension, how do we pay our doctors who are coming out with a substantial amount of debt in comparison to other specialties who are making a great deal of money in business and law right after college, right after graduate school?
So that's an excellent question, and frankly, this is what most of these struggles over scope of practice hinge on. It's much like the dentists trying to prevent dental technicians or dental assistants from doing things, and it's often argued in the name of safety, but you know and I know that much of it has to do with the people being scared about their living being taken away. So here's the good news. At the same time that people are nervous about having these things taken away from them, that a traditional way they made a living, we're also talking about this huge physician shortage that's approaching. And people are talking about opening up new medical schools and increasing medical school size class sizes. And where are we going to get all the physicians we need? And my answer is we don't need to train a whole lot more physicians. We probably have enough physicians now, if you think about physicians doing not what they did 20 years ago, but what they will be necessary for 20 years from now. So my answer to your question, which is an excellent one, and I know my answer may not be entirely reassuring, but it is, believe me, I think the truth. The answer is, I think that we can maintain physicians' income or we can maintain their scope of practice, but not both. If you'd like to maintain your income, it will be by your doing the things that we need someone with your level of training to do. There will always be a need for doctors. But if doctors insist on hanging on to tasks that are no longer doctor tasks, I guarantee you they will not be paid doctor pay for it. That doesn't make any economic sense. So I think the answer is we should simultaneously put a halt to this notion that we've got to train hundreds of thousands of more physicians who will then be arguing to maintain obsolete tasks in order to pay off their debts and maintain their income. Instead, we should think long and hard about whether or not we transfer tasks from physicians that no longer need to be done by physicians to others, to nurses, to pharmacists, to technicians, and to patients themselves, and we pay physicians a reasonable physician wage for things that we need physicians to do. Does that make sense? I know it's scary if you're on the receiving end of that debt, but frankly, there is no alternative.
Yeah, so I actually agree with you. You're making me think about some things. You talk about the scope of your work as all the income. You can't have both. And I'm like, that actually makes a lot of sense, as well as like the idea of training more physicians. You know, I know you're familiar with the fiscal year 2006 budget. They're talking about cutting GME, et cetera, et cetera. So It's just a lot that's going on, and it seems very uncertain I'm graduating, as a graduating medical student, what the future looks like for us. It looks very bleak, and it's kind of not frustrating, but
it's scary.
It's scary. Yeah, there you go.
Yeah, and I understand that part of the reason it's scary is because it's uncertain. I would argue that it's not bleak. I think it's uncertain. There's a lot that's uncertain. I can't predict where things will be 5 years from now, but I know this. I know that if physicians think that they're going to be able to maintain their income by doing the same tasks that they did 20 years ago, I know that will fail. I know that will fail.
Yeah, absolutely, absolutely. I've heard now, so I'm going to surgeon. I hear from surgeons all the time, like it's just not there anymore as far as the financial payout. For me, it's not really about the payout. It's about getting out of debt. For me, that's the, that's the biggest goal. I can live on a decent amount, but it's more so about not being swamped in debt.
Right. Well, debt is one of several factors that go into physicians' income requirements. They have expectations, they have debt, they have kids, all those sorts of things. But debt is certainly a big one. And I think there's one other thing that we've got to say. The income for some specialties, and particularly the discrepancy between the income for certain specialties and that of primary care doctors, has no relationship to how smart you are, how good you are with your hands, or any of the other things that are sometimes used to justify them. It has to do simply with the fact that there are some bureaucratic mechanisms that for a long time have been controlled by specialists that determine how much doctors get paid. Those things are changing. So I know that too is scary, because if you have $250,000 of debt and you're looking at the difference between what internists get paid and what ophthalmologists get paid now, and you choose a specialty based on the pay differential now, and you are right to be scared that that pay differential may not be there 10 years from now. I can guarantee it will not be. There's one other thing, particularly for those of you who are thinking about primary care, and I know this is one of the subjects you'll be talking about as part of this fellowship. A lot of the reason that you will hear some of your faculty members and some of your mentors whine and moan about primary care is money. But another reason you'll hear them whine and moan has to do with the life of a primary care doc as it has been for much of the last decade. And part of that, frankly, has been about how many patients you have to see in order to make the income that you require. There is help on the way. In the last several years, I've spent a lot of time at places that are adopting modern management methods in healthcare, Six Sigma, and in particular, lean management. So if any of you are in or around Seattle, you should go check out Virginia Mason. If you're in Wisconsin, you should go check out Theta Care. If you're in Colorado, you should go check out Denver Health. The primary care docs in Virginia Mason and Seattle, I spent 2 weeks with a leadership team with them in Japan 2 years ago doing lean management learning at the Toyota car factory and the Hitachi air conditioner factory. And part of what sold the primary care docs in Seattle on this Japanese auto manufacturing technique was that they now leave at 5 o'clock. I can't tell you what a change in the life. Those of you who are in academic institutions or doing clerkships, you will routinely see, the general internists, the primary care docs, the clinic may close at 5 and they're still there at 6:45 doing charts, making phone calls, refilling prescriptions. The docs at Virginia Mason leave at 5, and the reason they leave at 5 is because they've developed a system that allows them to get their work done in those 8 hours, and they will tell you that's more valuable than a $50,000 raise to them. So the good news, again, if you're hearing bleak news from some of your primary care colleagues, is that primary care docs who are in Kaiser are significantly happier. They're not all happy, but they're significantly happier as a group than the docs who are in private practice. And I think that trend of physicians joining groups which have, in part, the capability of operating at scale, managing their electronic medical records, having management systems in place that can provide them with teams that can do the non-doctor stuff, I believe primary care docs, in addition to having higher pay relative to specialists, will have better professional lives 10 years from now as these management techniques disperse throughout the healthcare system.
Thank you. I'm going to go over to Jordan now, since I know he has to leave for class.
Hi, Dr. Smith.
Yep. Hi.
So kind of my question pertains to the disintermediation of professionals and the self-care part of your presentation. Both of those, it seems like, as we transfer responsibility onto different professionals or onto the patient themselves, in 2015, when we have doctors doing these things, we bear a burden of responsibility, and we are held accountable. How is that going to change as we move towards other health professionals or the patient themselves? Who's held, responsible, and are we still responsible for educating both the patient and other professionals as we transition?
I think we're responsible for the things that we do best. So sometimes doctors' definition of a team is a group that I'm in charge of that doesn't impinge on what I want to do. That's not my definition of a team. On a team, everybody has a responsibility. So let's take education, for instance. You talk about education. There's very good evidence that diabetes education nurses do a better job over time of educating diabetic patients than doctors do. That's in part because they tend to be closer socially. It's in part because they have more time. It's in part because sometimes they've been trained on how to educate people. Do doctors have a role in educating their diabetic patients? Sure they do. But they may not be the principal educators. So on almost anything you can talk about, I think if you're operating a team, you can figure out who's the best person to do that thing. As for doctors being responsible, I don't know if you're talking about legally or kind of professionally. I will just tell you that there are lots of things that there are lots of over-the-counter medications now that required prescriptions when I was at your stage of training. Benadryl required a prescription. Advil required a prescription. I don't know if you knew that. Over-the-counter pregnancy tests. When these were first proposed, oh my God, I wish you could have heard the obstetricians. Oh, no one can uncut safe, and right? Well, so we work these things out.
Okay.
So it is not that it won't be without, and it won't be it won't be smooth. But as with many of the things that you have learned to do for yourself that used to require a professional, the more you do, the more comfortable you get, the better the tools are. And again, I sound like an old fart now, but you don't think anything of buying an airplane ticket on your phone. Let me tell you, the first time I bought an airline ticket online, my finger trembled as it went towards the go button because I had never done this before. But I got used to it, and the tools to do it got better. And what I'm suggesting to you is that healthcare is essentially a service industry, and these same rules of enabling technology, allowing lay people to do things that professionals used to have be necessary for, everything from writing a web page to diagnosing an illness, these things will become increasingly available. What I hope is that you don't see them as a threat to your professional status or to your role as a doctor. I actually think they can enhance our role as physicians if we can just get our mind around the fact that what physicians do 20 years from now will be different from what physicians did 20 years ago. And the reason is not because someone's trying to steal your income, but because the biomedical and engineering science has moved along.
It makes a lot of sense to me. How were the minds of the public changed so that we were comfortable with buying plane tickets on our phones, and we were, okay with buying, looking for houses on our phones? Like, what kind of rhetoric is necessary to kind of make people more comfortable with someone else or prescriptions being over the counter for a non-physician?
It's a great question. And I would argue that actually very little is necessary. I don't think anybody had to convince people. People didn't go out and give lectures about buy a ticket, why you should buy a ticket on your phone. People gravitated to the technology once they found it because it was convenient and it allowed them to do something they needed to do better. The fact of the matter is that the #1 category of things that people search for on Google after pornography is healthcare, right? So you don't have to urge people to find out stuff about their medical conditions. They're doing that whether you like it, whether I like it or not. And increasingly, I believe, if you make things available to people that meet their needs, they'll use them. So the best example to me, I don't know if any of you have ever gone to a Minute Clinic, or these retail-based clinics. I first started following these things about 6 years ago. I took my board to one about 4 years ago. Now, my board is mainly older people. They're kind of traditional. They all have health insurance. None of them is low income. And they all approached this a little bit skeptically, right? And they all came away saying, I would totally use one of these places. So let me tell you that if you have a screaming 7-year-old child that you think has an ear infection, and it's 1 o'clock on a Sunday afternoon, and your options are to wait until Monday when your pediatrician might be able to see you, or to go to the emergency room and wait 3 hours around a bunch of sick people and wind up with a bill that may be several $100s, or go to Walmart or CVS, be seen by a nurse practitioner in 20 minutes for $39, and if they need antibiotics, they're right there on the spot. You don't need someone to convince you to do that once you've done it once. You're there. So my sense is that, and again, remember, the reason we can do that is because we now have an ELISA test for strep throat that doesn't require fancy labs. Remember, all of these opportunities and challenges are the result of biomedical progress. So if you look at it that way, you've got to think about what biomedical progress will make possible in 10 years. So that's an example, I think, of people taking one step away from the doctor's office to this not doctor, usually nurse practitioner, not an emergency room, not a place that's a healthcare delivery site, but a more retail clinic. And you might have thought that people wouldn't do that, but in fact they have. They've gone in droves, in part because our system is so expensive, so inconvenient, only open when it's convenient for us to be open. And so patients have flocked to these new alternatives. And I'm pretty confident that as biomedical science allows us to do more and more, when they are made available to patients, patients will gravitate to them. So, Madam Moderator, I'm about out of time. Madam Moderator?
Oh, sorry, I was on mute.
Of course you were. I'm about out of time.
Okay. Do you have time for one more question or no?
Yeah, one more.
Okay. Gina, are you available? Gina? Gina, no. Okay. We have a student who's in the library, and she can't speak up, but she sent us a question.
Okay.
Can you hear me?
Yeah, Gina, are you there?
Yeah, can you hear me?
Yes.
Oh, thank you. Sorry, yeah. Yeah, I'm in a totally area, but yeah, my question, I'll make it really quick. This kind of patient engagement is just getting very popular nowadays. I'm just curious, right? Have you had any experiences with this, or do you have any like practical ways that you can get patients to be more engaged in their care?
You know, I'm sorry, but there's a big echo. I can't make out what you're hearing. Maybe somebody else can repeat it for me. I couldn't understand.
Yes, her question was on patient engagement. and how it's becoming a more popular term. And she wants to know practical ways that patients can become more engaged in their care, and any experience that you can share about that.
Yeah, you're right. Patient engagement is an increasingly used term, and I'm a little leery of it for this reason. I think people use the term sometimes to mean basically the same as compliance. In other words, by patient engagement, they mean, I want you to do what I told you to do. And that's the definition of you being engaged. You take your medicine or you get floss or whatever it is. A second way in which people use the term patient engagement is HR people, by which they mean we're going to increase your copays. So instead of going to the doctor for free, now you pay $50, now you're engaged. Neither of them, I think, is a particularly helpful way of thinking about patient engagement. I think financial responsibility is an aspect of patient engagement in the sense that if you're in an environment in which you are getting something for free, you tend to use it without thinking too much about how necessary it is. So this, of course, is a very slippery slope, and we don't want people to be denied unnecessary care, just kissing my wife goodbye, but we do want them to think about whether they get that MRI or not, and having to have them pay something for the MRI certainly gets them to at least think about it, although, as I say, it's a slippery slope. Another aspect of patient engagement, I think, has to do with their understanding their disease, and here's where better mechanisms to educate people about the preventive nature of our interventions and the things they can do to prevent sequelae is more important. And a lot of this, frankly, has to do with understanding patients in ways that the healthcare system doesn't do very well. If you think about what Walmart knows about you, or what Google knows about you, or what Amazon or Netflix knows about you, your family structure, your interests, your passions, your fears, we know almost none of that about our patients, even patients we've known for years. We know your weight and your G6PD deficiency, but if you think about the sophistication with which many others in the retail sector understand their patients' psychology and social circumstances and risk averseness, these are the sorts of things that we need to get much better at in getting patients to do the things that we'd like them to do. And so one of the really interesting opportunities we have, I think, is to think about how this big data that everyone's now interested in, much of which comes from the retail sector, might be combined with our healthcare data to understand our patients in completely different ways. We tend to categorize patients by their quote, race, unquote, which we know is kind of a social construct. We might categorize them by the language they speak or by their BMI, but we have no idea where our patients are on the early adopter or laggard scale, or how risk averse they are, or what their social influences are. And so I think one of the big areas of interest, and people are now investing lots of money in it, in the next 5 to 10 years will be saying, you know, I've got 1,000 hypertensives. These hypertensives can be sliced and diced according to their weight and their blood type, but Amazon slices them and dices them in very different ways that might be helpful to us in healthcare to understand how to motivate patients in their own lives to do stuff. Then the last place of patient engagement has to do with this self-care thing that I talked about. And, you know, I take care of mainly low-income, mainly men with HIV. And I always bristle when people start talking about what poor people can't do. They're poor, they're not stupid. And just because they're low income doesn't mean that they're not able to understand their disease and actually play a major role in managing their disease. So I think we vastly underestimate what patients can do for themselves, and I think these experiments with things like self-dialysis and hypertension treatment should be a wake-up call for us that part of the way to get people truly engaged in their care is actually give them responsibility for making some of the decisions that we have traditionally made. Now, we've got to prepare them and train them and protect them and give them enabling technologies, but the notion that they are passive vessels to be acted on by us, I think is both unnecessary and not optimal in terms of the outcomes that we want. So that's how I would talk about patient engagement, both educating them about their disease, understanding them much better from the standpoint of the kinds of attitudes, social beliefs, interests, capabilities that retailers typically know much more than we do, and then often getting them involved in making decisions about managing their disease, many of which I think they're capable of making on their own, and once they're making the decision, I think they tend to own it more, much as we do with most of the decisions that we make. I don't know if that answers the question.
She says it does. Thank you so much. I know that you said you had to run, but thank you very much for taking time out of your day to speak with us on this topic.
It's my pleasure. Good luck to all of you. If there's anything I can do to be of help, get in touch through NMF. They'd always know how to reach me, and best of luck to everybody.
Thank you.
All right. Bye.
Bye.